Good morning, students. I'm Dr. Shyamala from Department of Orthodontics, and today we are going to learn the topic diagnosis and treatment planning and how to write a referral letter, right? So it is very important for you to know this topic because ortho is all about diagnosis. If you diagnose a case properly, then you can arrive at or formulate a good treatment plan. If you don't know the diagnosis, if you um, have a problem with the diagnosis, and if you didn't diagnose properly, the entire treatment plan will go wrong, right? So just please concentrate on this topic, and I will be telling you in detail about it. Now in this class you will be learning about how to define diagnosis and what are the various diagnostic aids that we use in orthodontics, explain the sequence of extraoral and intraoral findings, outline the extraoral and intraoral findings, assess the growth by skeletal maturity indicators, discuss the provisional diagnosis based on its findings, and compare the different types of X-rays which are used in diagnosis. Now, basically, a diagnosis is when you see a case, okay, and you summarize the case, which includes your skeletal problem, your dental problems, and your soft tissue problems. It is called as a diagnosis. It is comprising or a summary of your entire case, right? It's called as a diagnosis. To put it in a very simple term. Now, if you have to give a definition, okay, Graeber and Roccosi gave a definition as the recognition and systematic designation of anomalies, the practical synthesis of findings, permitting therapy to be planned, and the indication to be determined, thereby enabling the doctor to act. That is called as a diagnosis. A general dentist must recognize the various characteristics of the malocclusion and the dentofacial deformity, understand the nature of the problem and the etiology, and design a treatment plan on the specific needs of the individual. The goal of your diagnostic procedure is to produce a complete description of your patient's problem, okay, and make a problem list. A treatment plan is derived from its problem list. Now, if I have to put it very simple, okay, now understand this. Okay, don't see the slides, just listen to what I am telling you, right? So, a diagnosis, as I said, is a summary of your entire case, right? You have written every single detail which is important clinically or for your treatment plan in your diagnosis, okay, which involves your skeletal problem, your dental problem, and your soft tissue problem, right? So everything you have written in your diagnosis. Now from this diagnosis, okay, what are the issues you want to correct? Yes, I repeat, what are the issues that you want to correct from your diagnosis will be in your problem list. If you take your ortho case sheet, okay, it is divided into diagnosis, problem list, treatment objectives, and your treatment plan. You must understand the difference between all the four, right? So I would like to tell in detail. So as I said, a problem list is from your diagnosis what all you want to correct, okay, so it will be in your problem list. For example, you see that a patient is having a class 1 malocclusion, okay, and a class 2 canine relation, okay, so in your problem list you will not write the class 1 molar relation, right, because that is not a problem. You will be focusing more on the canine relation. For example, everything is okay in the patient. Okay, he has a class 1 molar, he has a class 1 canine, he has an no crowding spacing, but just he has a rotation, okay, a single tooth rotation, or he has a midline diastema, right? Just a midline diastema, okay, and the patient has come to you, okay, so your problem list will include only the midline diastema. Yes, so that is the thing. Now, once you're clear with what is a problem list, what is a treatment objective, right? A treatment objective is you have now written your diagnosis. From the diagnosis, you know what are the problems that you want to correct, and from this problem list, step by step on how you will correct it will be your treatment objective. Okay, so how you're going to do, for example, first is your molar, you want to correct the molar, then your canine, then your incisor. Okay, then individual tooth problems like your crowding, spacing, rotations, and everything, right? So treatment objective is what you want to achieve at the end of your treatment. Okay, that you will write it down in your objective, and with what you want to correct all this objective is your treatment plan. Whether you're using your removable appliance, you want to use your fixed appliance, you want to use growth modification, or you want to go for surgery, right? So that you will determine based on your objective what you want to correct, right? So I hope that is clear. So we will move on. Okay. Okay. Now there is something called as a database, right? A database is basically formed from three sources: the history that the patient gives you, okay, clinical examination that you do, extraoral, intraoral, and functional examination, and the records that you have taken for your diagnosis, okay, and how you analyze and what you derive from that analysis, right? So the results from the analysis, all this comprise and it will be put onto your database. Now this is very important. This is your short answers and your MCQ question and even your short notes, right? So classification of your diagnostic aids. Now diagnostic aids, okay, it was given by Graeber, T.M. Graeber, and he divided into essential and supplemental diagnostic aids. Now essential diagnostic aids are those diagnostic aids which are essential for your treatment, and you need them to plan your treatment plan. Okay, that involves first and foremost your case history, your examination, definitely you have to do that, your study models, okay, your radiograph. Now the most common radiograph that we take in ortho are your OPG and your lateral ceph. Lateral ceph to see the skeletal, if the problem is skeletal dental, and also to see the growth of the patient, okay, and OPG to give an idea of the entire arch, maxillary and mandibular teeth inside, right? And also very important that comes under your essential are your photographs, right? So you must take pre-treatment and post-treatment photograph, not only for you and for medical legal cases, but because to ensure that the patient also that how much you have achieved from pre to post, right? So that is also very essential. Now supplemental diagnostic aids are aids that you don't require for every case, but definitely you require for some situations, right? So lateral and frontal cephalograms, okay, in some cases your functional records, your occlusal radiograph, hand wrist x-rays, okay, selected jaw views if you require, EME, AMG, and your BMR, okay. All right, so a comprehensive diagnosis will involve your case history, clinical examination, your functional analysis, your cephalometric analysis, photographic analysis, radiographic examination, and your model analysis. No need to see this. This is the same thing that I was talking to you before. Okay, so I just want you to concentrate on that. And when the class resumes and you start taking your case histories, I'll be talking more in detail on how do you take it in your preclinical exercise, right? On how to take a proper case sheet and what all you see. I just want you to listen to this class so that it doesn't sound Greek and Latin when I give you the demo. Okay. So just read and listen to what I'm talking here. Now, moving on to the heart of the class, which is your case history taking, right? So case history is very, very important. Okay, not only for you to just write it down, but it also helps in medical legal cases, right? It is very important that the patient has come to you, you have taken a detailed case history, right? So, and you have jotted down and asked each and everything, right? So it is very, very important in that aspect. Now, if you see an ortho case sheet, there are 4 or 5 pages, and each and everything in the case sheet is very, very important. Everything has its own significance and a reason and a link to why it is there, okay, related to your treatment plan in your orthodontics, right? So carefully understand each and everything that I'm talking here, right? First and foremost, personal details. Now, under personal details, you will mostly see name, age, gender, and occupation, right? So why do you think it is important to know the name, right? So as I said, each and everything is very, very important and it has to be recorded properly when you take a case history, right? A name is important and it has to be recorded for the purpose of identification and communication and also for medical legal records. Age is very, very important, okay? So age, as we all know, okay, what are growth spurts, okay? So you know that when it is say about the child has come about 8 to 9, you know what to expect, okay? There is a range. If you know that there is a growth still there, there is a chance, then you can think about what appliance. As you all know, okay, you have to understand here that for every patient, we don't go and put braces. It depends on whether the child is growing or not growing. If the child is growing, you don't put braces. You give something called as growth modification appliances, right? Which is your orthopedic and myofunctional appliance, which you'll be learning later, which is a bulk of a subject, right, on its own. So just understand the term that for every age, we don't give braces, right? Braces is given only when the patient is having full set of permanent dentition, okay, and the growth is completed, right? So then you go ahead and put braces for the patient, right? Gender is very important as I spoke about growth spurts, males and females, boys and girls grow at a different pace. They all don't go at the same age. You cannot expect everybody to, eruption to be happening at the same time, okay, calcification at the same time, okay, and then shedding at the same time, okay. So every child and every individual differs, okay, so you must understand the timing and the gender, okay, of the growth spurts. Next is address and occupation, okay. It is also important, okay, in some cases in orthodontics to know the occupation, okay, of the patient, okay, not only in orthodontics, in other departments also. For example, some patients, okay, for example, they work in a pin factory, okay, so they keep on putting the holding the pin. If you see the workers, local workers, right, they put the pin in the front teeth, okay, so they keep on putting there, right? Even in, if you see some tailors, right, so there is a crack, okay, in between your incisors. If you keep for a long time, you can expect that to be a midline diastema in the future, okay. And also it is important because, as you all know, ortho is a little bit of an expensive treatment, right? So whether they can afford it, right, or you can, give some other options which is in par with their economic condition, right? So that is important. Next is chief complaint. It is very, very, and I quote, very important to know the chief complaint of the patient. This is the first thing that you have to address in your treatment plan. Yes, chief complaint. Okay. Now, if a patient has come to you, say he has a class 2 molar relation, and he reports to you with a midline diastema, yes, so your job is to first address the midline diastema, right? Because the patient is having no problem with his class 2, okay? Although you can give an option to correct the class 2, okay, you must give him the various options, but the first thing to be addressed in your objective or your treatment plan is the midline diastema, if that is what he has come to you for, okay. So that is also in related to your medico legal cases, okay. So it is not always about the money, okay, it is about ethics also, right? So you must listen to what the patient wants, okay, and as they say in your pledge, service to humanity, right? Humanity comes first. So patient's chief complaint should be recorded on his or her own words. Okay, that means you don't use some orthodontic hi-fi terms like your prognathic maxilla and your proclined upper anteriors. You just say patient has come with a gap in between your front teeth with forwardly placed upper anteriors, okay, and forwardly placed upper jaw, gummy smile, right? So all those things should be in layman's terms, right? This helps the clinician to identify the priorities and the expectations of the patient. Now, reasons for orthodontic treatment is very important. As you know, ortho takes about 1.5 to 2 years, okay? And at the finishing stage, usually it is all dependent upon the patient, okay? And also in the initial stages. If the patient is not motivated, right? If the reason is not motivated by himself or herself, okay, there is no way that your treatment is going to end up in desired results. Okay, so if the patient is motivated internally, especially the child patient, okay, if he or see you see a braces at least you have to go to orthodontist say about every month. Yes, 98% of the time you have to go every month for your changing wires and activation and all the other stuff. But in a child, you give the growth modification appliance. It is totally dependent upon the child to wear it, right? So unless and until the child is not wearing it, okay, you cannot get the desired result, right? So you have to know, and if the patient is not motivated, it's your duty to motivate and make him understand the consequence of what will happen if or he or she is not wearing the appliance, right? So reasons for seeking the treatment can be because of aesthetics, functional, hygiene, or speech related issues, right? Now, family history is very, very important, right? It is very important if you for you to understand that genetics plays a very, very important role in most of the cases when you see a malocclusion, right? 50% at least. So if the parents and siblings are having malocclusion, you expect the offspring also to have the malocclusion, right? So if there is a family history involved, if there is a genetics involved, you know that the chance of relapse is double, right? So it is important for you to take a history. Now, medical history is very important again, okay? So it is important to write down the medical history of the patient in detail. For example, if the patient has reported to you and he is a diabetic patient, okay, it is very important for you to write down, okay, his sugar level, okay, what is the current fasting and postprandial blood sugar level, okay, if he or she is taking any medication, okay, and if so, what is the current levels, and if he or she has a letter or from her physician stating that he or she is capable of undergoing orthodontic treatment. To put it in a simpler way, okay, if a patient is diabetic, okay, high level diabetic I'm talking here, okay, and if you Google it and see, okay, there has been a death in dental chair also with a simple poke of a wire, right? There has been cases. Excessive bleeding happens and the patient has been, you know, gone to a coma stage and even death in some cases, okay, with profuse bleeding, okay. Of course, in ortho, not to that, but when you do an extraction in a diabetic patient, you can expect a worse scenario there, okay. So it is very, very important to understand, okay, that it is important for each patient with a medical history to get a green signal from the physician, to get a letter from the physician stating that he or she is ready to undergo dental treatment, right? So now moving to dental history, right? It is very important to write down the past dental history of the patient. For example, his extractions, restorations, previous treatment, okay? And especially this plays a key role in when you're treating a child patient, right? So if the mother or the father have said that the patient has undergone a past restorations or extractions of 4 to 5 teeth, you know that the patient has sat through the entire procedure and is cooperative enough, right? So you know what to, it's not that you're not going to treat a patient if he or she is uncooperative, it's just that you need to mentally prepare yourself on what you're going to, see, right? So it gives some time for you to plan out, right? And understand that this is not going to be an easy case, right? Because as I said previously, treating a child is very, very important. Okay, you know, if you will learn in your subsequent class that a growth modification appliance, if a headgear is quite a bulky appliance, right? And it is not very aesthetic, I can assure you that, right? So if a child has to wear that, okay, he or she has to be cooperative and motivated enough, right? So next is prenatal history. Now, why is it important for you to understand what happened uh, prenatally, even before the child is born? What went wrong? It is basically to understand the etiology of the problem, right? So if you know the etiology, as I said, it affects your treatment plan, right? So prenatal history, health of the mother during pregnancy. Okay, now as you all know, um, a mother with good health, okay, or any deficiency, it definitely affects the child in the womb, okay. So that diseases, bacterial and viral, any medications, radiation and trauma. So all these things are very, very important for you. You, of course, many of them won't even remember, but if they do, please write it down. And if you don't know, then you must write no relevant history given. Okay, if you just leave blank, it means that you didn't ask, the patient didn't tell, what is it? It's very important for you to write no relevant history given. Okay, so you ask the patient doesn't know, right? Okay, now very important here is the mother that I was talking to you about. Okay, what can go wrong during the birth? Now, there is an interesting fact here. Something called, as you all know, there is normal delivery, there is cesarean, and there is something called as a forceps delivery. Okay, now forceps delivery, although very rare, but it's still been practiced. Yes. So what happens there? Now, when you know that the baby is coming from the birth canal, right? So they put a forceps, two strong forceps, right? So it is like a prong, and you just hold the baby's head and you try to push it out. Now you can expect where the prongs go. Okay, so it goes near your TMJ, right? So it holds the mandible and they push it out. So imagine the amount of pressure that they put to hold the baby and they try to pull it out. So when that happens, okay, there is definitely an effect on the growth of your mandible, right? Yes, so when you put that much of amount of pressure there, you can expect some deficiency there. Right? So it is important to understand and ask the mother where how the delivery was, if she recollects, right? So postnatal history is basically the type of feeding. Okay, bottle feeding. If so, how long? Okay, have it till what year? It was there. Presence of habits. If there are habits, then time, frequency, and duration has to be recorded, right? Milestones. If everything was in order, or the child is a late developer. Moving on to your clinical examination. Okay, so under clinical examination, you have general, extraoral, functional, and intraoral, right? Under general examination, you have to write height, weight, and gait. Now, I hope you all know how to take the height and weight and gait. Okay. Now, coming to body build, okay, there are three types: aesthetic, plethoric, and athletic. Okay. Aesthetic means the physique is thin and the dental arch is narrow. Plethoric means obese with large and square dental arches. Athletic is sturdy and well proportionate body, okay, with normal dental arches. Now, body type is by Sheldon was divided into ectomorphic, mesomorphic, and endomorphic. Okay, so ectomorphic is tall and thin, meso is average, and endomorphic is short and obese body type, right? Now, how to measure the shape of the head? So Martin and Zeller gave some measurements, okay, and a technique on how to measure the shape of the head. Okay, so maximum skull width. Okay, so maximum skull width, the distance between the tangents of your parietal. This is the parietal bone. So parietal bone and your skull length, the distance between the tangents to the frontal to your occipital bone. Okay, so this is your skull length. The equation goes cephalic index is equal to maximum skull width divided by maximum skull length into 100. Okay, so if you get a measurement less than 75.9, that means the head is dolichocephalic, that means long skull, long face. Okay, so 76 to 80.9 is mesocephalic, normal. 81 to 85.4 is brachycephalic, which is a short skull, and 85.5 is less than that, is your hyperbrachycephalic. Now moving to the facial form, okay. So there is again an equation for it. Morphological facial height, that is the distance between your nasion, okay, the tip of your nose, between your two eyes, okay, the nasion to your gnathion, okay, here, right? And then your bizygomatic width from your one zygoma to the other, the distance between the tangents of your two zygomatic points. Don't worry, we will be learning again when I will be showing you. Once the class resumes on the patient, you will have a better idea on how it looks like, right? Okay, so the equation goes morphological facial height divided by bizygomatic width into 100, right? So mesomorphic facial form is average and normal facial form. Leptoprosopic is your long and narrow. Hyperleptoprosopic is your extremely long face. Europrosopic is your face is broad and short, and hyperuroprosopic is short with low facial index. Now, I want you all to see this picture and understand on how it looks like, right? So, mesoprosopic is your average face, okay? So, and your normal arch form, right? Whereas your leptoprosopic, as I said, is long and narrow. So, definitely you expect the arch to be V-shaped. And europrosopic means short and wide, okay, so square shaped, okay. So of course in your arch also you will see a square shaped arch form. Now facial symmetry, how do you see? Okay, so facial symmetry is basically horizontal thirds and vertical fifths. We'll be learning that. So horizontal thirds, okay, so this is your upper third, this is your middle third, and this is your lower facial third. Okay, so if you see all the three thirds are in equal size and planes or measurements, it means that your face is symmetric. Okay, so vertical facial form. Okay, so vertical fifths. So you draw a midline 1, 2, 3, 4, 5. So this is vertical fifths. So you draw a midline over here. Okay, draw a line perpendicular from your inner canthus of the eye. Okay, and draw a line from your outer canthus of the eye. The same follows for this side. If you see all the fifths are, you know, almost this side and this side is equal, right? That means it is equal on both sides. Okay. So facial height. So upper anterior to lower facial height ratio is usually for the upper is 45% and lower is 55%. Anything more than that, of course, there is an asymmetry, right? Now facial profile, you will see three types of facial profile: straight, convex, and concave, right? So straight profile, as you all can see, is from your nasion to your chin, right? Forehead to the chin. Next is your convex, okay? That means your mandible is way behind. Now, in which case do you see a mandible behind? Yes, skeletal class 2. Okay, so you see mostly with a mandible behind in a class 2 patient, and a class 3 patient will have a concave facial profile, right? Now, facial divergence. So you have again three types of facial divergence. You have your anterior, you have your straight, and you have your posterior divergence. Okay, so anterior divergence you mostly see when your chin is forward, like in a class 3. A straight divergence means it's all normal, orthodontic, and you see posterior divergence, okay, when your mandible is behind, okay, that means in a class 2. What is a clinical FMA, right? A clinical FMA is the angle formed between your Frankfurt horizontal plane, which is a plane connecting your external auditory meatus to the inferior border of your lower eye, and your mandibular plane. Okay, so this angle is called as Frankfurt mandibular plane angle, right? If you see this angle is 25 degrees, that means it's normal. Okay, so if you see it is more than 35 degree, that means the face is, the angle is increased. Okay, that means the patient is a vertical grower. Okay, it's a high clinical FMA, right? And if it is lower than 15, that means patient is vertical growing. Okay, so low facial clinical FMA. Now, nasolabial angle, right? So, nasolabial angle is basically the angle formed by the tangent of the lower border of the nose to your upper lip, right? So, basically, this angle is around 90 to 110 degrees. Okay. Examination of the lips. You can write either the lips is normal, short, thin, thick. What do you see? And whether it's competent or incompetent lips. So incompetent lips, basically when you say anatomical, is because anatomically it is like this. Okay, if it is dental, it's because of the teeth. Okay, and if it is a mouth breathing, it's physiological. Okay, now lip trap is mostly seen, and I quote this, it's very important for your MCQ question, your short answers question. Yes, so a lip trap is most commonly seen in a class 2 division 1 cases, okay, where it prevents a proper seal, okay, and where your lower lip is trapped in your incisors, right? Okay, tonicity of the lips, you must write whether the lips are hypotonic or hypertonic lip. Now a chin, you must write whether the chin is normal, whether it's shallow here like this, or it's deep. Okay, the mentolabial sulcus. And also whether the chin is recessive or prominent like your class 3. Now functional examination, there are a few topics that comes under that. Is postural rest position, okay, which is also called as a freeway space. Basically, a freeway space is the space when the patient is at rest, when he closes the mandible, okay, the distance between your upper and lower teeth is called as the freeway space, right? It is also called as interocclusal clearance. Okay, so it is, you can achieve this position when you repeat the term Mississippi. Okay, or you can do is you can tell the patient to bite, you write down the distance of the measurement, then you tell the patient to swallow, okay, then you write the measurement, and then you take the difference between the both. Don't worry, we will be doing it in our demo, so you will understand, right? So normally it's about 3 mm in the canine. Okay, as I said, postural disposition can be done with phonetic method, command, and non-command method. Okay, and by vernical calipers. Okay, so vernier calipers is something that we use to measure the distance, right? So I'll be talking in detail in our demo. Now, path of closure, there are three types of path of closure. One is your forward path, your backward path, and your lateral path of closure. Okay, so just know the names. Of course, in this topic, it is easier when I show you with the patient, okay, and make you understand, right? So just know the names. There are three types of path of closure. Okay. So respiration, of course, there is oral respiration, nasal and oronasal, right? Examination of TMJ. Okay, you all know how to examine a TMJ. Basically, you go behind the patient, make the patient sit upright. Okay, put your index finger and your thumb near the TMJ and tell the patient to open and close the mouth. If you hear any crepitus or clicking, you need to write down, right? Maximum mouth opening is the distance when the mouth is open to its maximum size, right? So from your tip of your upper upper teeth to the lower teeth is your maximum mouth opening, right? It's usually around 40 to 45 mm. Examination of swallowing, you must know whether it's an infantile swallow or a mature swallow. Okay, infantile swallow is basically when you thrust the tongue out and swallow because there is no teeth. Okay, and mature swallow is what you all are doing now, right? So examination of speech is very important, okay, because to know whether the patient is having a problem called as lisping, right? So you ask the patient to read out from a book or ask to count from 1 to 20. There are also some difficult alphabets that help you to identify a lisp, which is the S and the Z sound, okay? So, okay, the patient will have a difficulty in pronouncing that. Intraoral examination. So what do you see under that? Soft tissue examination, you check the oral hygiene of the patient, you check the gingiva for any redness, inflammation or any pathology, and you check the tongue, whether the tongue is macroscopic, microscopic, okay, any pathology there, right? Then you see palatal contour, whether the palate is high arch, whether the palate is low arch or medium arch, right? Then you see frenal attachment, okay? So whether the frenum is a normal position or it's in the attached gingiva between your two incisors or what. This is very important to identify, okay, when your patient is having a midline diastema. You know if the frenum is the problem, right? So etiology is very important. So Blanch test is a test that we use to identify whether the frenum is the problem for the midline diastema, right? What do? Is you stretch the upper lip of the patient, then you see a blanching, okay, a white. When you stretch a tissue, what do you see? Okay, lack of blood flow there and there is a blanching, right? So you can all Google and search how a blanching looks like. Now, hard tissue examination, I'll be not going into detail about it, okay, because you all know how to write the number of teeth present, if there is any unerupted teeth, supernumerary teeth, missing teeth, shape, size, and form, okay, caries, if so, in which teeth, endodontically treated teeth, and occlusal wear, and if so, it's present where. Maxillary and mandibular arch. Okay, so when you see maxillary mandibular arch, it is important to write what kind of arch form it is and if there is any individual tooth abnormalities. If so, write which tooth and what type of abnormalities. If it's a rotation, if it is a spacing, if it's the alignment. Yes, so you have to write in detail. Next is inter-arch relation. That means whether the molar is in a class 1, class 2, class 3, whether the canine is in class 1, class 2, class 3, and incisor in class 1, class 2, class 3, right? So I assume you all have already understood the how to classify the molar canine and incisor relation in your third year itself under the topic classification of malocclusion. So I'm not going into much detail here, right? Now there is something called as overjet and overbite, right? So these are vertical plane malocclusions, right? So an overjet, okay? So overjet is a sagittal or horizontal plane malocclusion, right? And overbite is a vertical plane malocclusion. So don't get confused there, right? This is called as increased overjet, right? And this is called as a reverse overjet. Vertical relationship, you will see an open bite here or a deep bite here. Okay, open bite where there is failure of fusion of your upper to the lower teeth, and your deep bite where there is excessive overlap of your upper and lower. Transverse malocclusions are mostly your crossbite and scissor bite. Okay, so when we start our classes, I'll be showing much more cases on how a crossbite and scissor bite looks like. Okay, so analysis of your diagnostic records, as I said, just with yourself or your clinical photos, you don't derive a treatment plan. You have to analyze your entire records to come to a conclusion on how you're going to plan out your treatment plan, right? Okay. As I said, a problem list, okay, is basically divided into, based on the Ackermann profit classification, as you all have studied in your third year: facial proportions, alignment, anterior-posterior relationship, vertical relationship, and transverse relationship, right? So under each heading, if you have a problem, you write. If it is not a problem, please don't include in your problem list. And your treatment objectives from your problem list, what all you are going to do stepwise, how you are going to treat it will be your treatment objectives. And a provisional treatment plan is how you are going to treat all this that you have written it down is your treatment plan. Now I want this, usually I do in a class, okay? So on you to see the case and diagnose it and write down what is the problem, and for you to determine a treatment plan for it. So never mind, I want you all, I'll be giving few assignments in your Google Classroom, okay, so that you can understand the concept. I'll be posting a series of clinical cases there, okay, and you have to write a diagnosis and formulate a treatment plan for it, okay, at least to know how to write a diagnosis, right? So this exercise I'm skipping, okay, so we will be doing in a Google Classroom soon, okay, but if you are interested, just see the case and write, right? So I have written objective and treatment plan here. See if your diagnosis or your treatment plan is matching with this, and understand the concept, right? Okay. Now moving on to our next topic, which is our treatment planning and referral letter writing, right? So at the end of this lecture, you should be able to identify some of the common malocclusions and how to derive a treatment plan, right? So treatment planning is the second step in the treatment of a patient, the first step being the diagnosis. It entails the formulation of your entire detailed problem list, okay, your objectives, and finalizing a treatment plan, okay. So let me just skip through this and come to the main of the topic here. This is important, okay. So rest all we can, again when the class resumes you can understand, but this is very important. Okay, how do you plan the space? Okay, how do you know whether you want to extract or not? Okay, it depends upon, okay, how much you want to retract, how much you want to correct the crowding, how much alignment is required if the tooth is rotated, okay, correction of molar and leveling the, right? Now imagine you want to retract a protruded teeth. Understand that for every millimeter of retraction, okay, 2 mm of space is required, because both, suppose you are retracting your two anterior teeth, okay, that means 1 mm, 1 mm on both sides, that means 2 mm of space you require to retract the teeth, right? And if you want to correct the crowding, okay, so for every mm of decrowding that you have to do, that much amount of space you require. Okay, simple. So I don't want to go into very detail about it. I'll be doing again in the class in during your demo. So alignment, and same as for rotation also, the amount of space available and amount of space you need to derotate it, okay, that is what you need to understand and decide whether you want to go for extraction or you want to go for proximal or half. Okay, now correction of molar relation, okay, the space required, whether you want to move the molar mesially or distalization of molars is required, depends upon how much space is available and how much you want or you need, right? And also leveling the curve of P, for every 1 mm of leveling you require 1 mm of space. So how do you plan and anchorage? What is an anchorage? Anchorage basically means support, right? So basically your molar is the anchor teeth that we use mostly, okay, for your support of your braces, right? So all efforts should be taken to minimize unwanted tooth movements. Failure to plan anchorage results in failure of treatment mechanics, right? Okay. Anchorage demand will depend upon number of reasons. Okay, the first and foremost is number of teeth being moved. Okay, so the greater number of teeth being moved, the greater demand is on anchorage. The type of teeth being moved. Okay, so they say that tooth movement involving multi-rooted posteriors, okay, they offer a great strain on anchorage than moving the smaller teeth. Now, a type of tooth movement. Okay, so tipping movement requires less pressure on anchorage compared to the boarding movement. Okay, and if the treatment is going on for a very long time, that means the anchorage loss is there. Okay, you can expect some anchorage loss there. Excuse me. So selection of appliance. Okay, so how do you select an appliance? Okay, so it is based on number of factors: the type of tooth movement required, patient expectations, growth potential, patient's ability to maintain oral hygiene, cost, and the skills of the. Now, when I say type of movement required, okay, these simple tipping movements or simple malocclusions can be corrected using removable appliance. Whereas if it is a complex malocclusion, you must know whether you want to give a fixed orthodontic treatment, you go for surgery or how. Right? So, patient expectations, okay. Okay, so when the patient is having a high expectations like social, patient is a social person, okay, and he needs more focus on the aesthetics, then you cannot just give a fixed orthodontic stainless steel metal braces, right? So you have to go for something advanced, and whether if the cost is not a problem, then definitely you have a lot better options there. Okay, so patient expectations is very important on how and whether the patient is unaffordable and whether you can still correct it with removable appliance. You have to do that. Growth potential, as I said, right? So you have to know whether the patient is growing or not. If it's growing, you give an entire range of different appliances. If the patient is not growing, then you go for an entire range of other appliances. The cost, as I said previously, okay, so depending upon the economic condition of the patient and the situation, if you can handle it with removable appliance, you can do so. If not, then you give the options to the patient, right? Now, planning retention is very important. Okay, definitely you cannot go ahead and say that ortho treatment is not going to relapse. Okay, there is a tendency for every case to relapse. It is important for and the skill of the clinician to understand and plan out a treatment and to give a proper retention plan to prevent relapse. Now, why a relapse happens is basically because of your stretch medial ligament. Okay, if the occlusion you have achieved is unstable, and because the patient is still growing and you have removed the braces, right? So many things can lead to relapse. It is very important for you to discuss with the patient and get a sign of the patient consent that you both agree to the treatment plan and you have seen all the other options and you have chosen this treatment plan for the particular patient. Okay, it is important for you to write it down and get a sign from the patient to for your medical reasons also. Now, a referral letter writing is very important for you all, right? As a general dentist, you must know how to write a referral letter. Just see and treat the case is not good professional behavior, right? So, how do you write a referral letter, right? So, few things here you have to know. Okay, so you are all professional here and you have to write, you are writing to another professional, right? So it has to be in a much more detailed way. It has to record all the necessary details of the patient, okay, and what you have done till now. So you have to include the patient name, address, code, age, date of birth, and full accurate contact details. The reason for why you are referring and what the patient complaint is, any medical history if the patient has given you, how long they have been a patient with you and whether they attend regularly for your checkups, the standard of oral hygiene that they have, previous dental treatment, if so, what are the teeth and what treatment was done, any history of trauma to the face or teeth that you know of, any social history related to the treatment if it will hamper it, and motivation for treatment. Right? Okay, so basically when we say summary, you have to write, it includes everything, right? Your skeletal and dental problems, your crowding, spacing, incisor, molar, overjet, overbite, the IoT and everything, right? And the copy of it with your photographs printed, okay, any recent, and also the pre-treatment photographs. Okay, if it's there, it should all be included in the letter, and if there is a study model, you can duplicate and give also. Now this is an example of a referral letter. Okay, so I'm reading through it. I want you all to concentrate and focus here to see how to write a proper referral letter, right? So, dear Mr. Y, right? So you are writing the name, the address, the detail, and all the other things here. I would be very grateful if you could arrange to see Anne regarding her severe class 2 division 1 malocclusion. So it is a request, right? You don't go and you just say, okay, this is the problem, so see this patient and treat this patient. Okay, Anne is being teased at school and is reluctant to smile because her top teeth is stick out. So as I said, it is in layman's terms. Okay, the chief complaint of the patient has been written, and the reason for which the patient had come to you previously has also been mentioned here. Okay, Anne and her family are new patients to me, but have been regular attenders at this practice for many years. Right? So you know that the parents and the patients are cooperative, and they have been coming for the dental treatment for many years. Right? Her oral hygiene is generally of a very good standard. Okay, so oral hygiene is written here, but I have recently given some oral health instructions in relation to the first molars, right? She has not had any experience of dental treatment in the past and is currently dentally fit. Medically, she has mild asthma. Okay, so medical history is very, very important and has been mentioned here, for which she takes salbutamol inhaler when required. Okay, Anne and her mum are very keen for her to have treatment and understand what is involved with orthodontic treatment, as Anne's older brother had treatment at your practice a couple of years ago. Okay, so they understand the problem, they know that it is going to be 1.5 to 2 years of treatment, there is going to be some pain, so they have all gone through it previously and they understand the problem, right? In summary, now we are going to the patient's diagnosis, okay, and a detailed problem list here. In summary, Anne is 10 years old and has a class 2 division 1 malocclusion on a moderate class 2 skeletal base with a decreased vertical proportions and incompetent lips with a lower lip trap. Intraorally, she is in a normal early permanent dentition for her age. The lower arch is well aligned and the upper labial segment is proclined and there is a spacing, right? In occlusion, the overjet is increased to 12 mm and the overbite is increased and complete to the palate. The molar relation is a full unit, class 2 bilaterally. There are no cross bites, no displacement of the mandible. I have not taken any radiograph and there has been no clinical justification. Okay. I understand from Mrs. Other that Anne has been growing rapidly for the last 12 months, and so I would be very grateful if you could see her with some urgency in case she requires a functional appliance to correct the malocclusion. So here there is the here they have you mentioned about the urgency of the problem because the patient is at the peak of the growth spurt. Okay, so any appliance growth modification will be very helpful here. Okay, many thanks in anticipation of your help with Anne's orthodontic treatment. Yours sincerely, so and so. Okay, so this is how an referral letter will look like, right? So in detail about all the problems, right, is summarized into this referral letter. Okay, so basically in your when you start the class resumes, I would like I will give an exercise or I will ask you all to do in a Google Classroom to write a referral letter, okay, for you to understand how it should be written, right? So that's all, everybody. Thank you. And I hope you are all staying at home and being safe. Any doubts regarding the lecture, please post it on ePortal or send a private message in your Google Classroom. I'll be posting few assignments and for you to do in the classroom. So please keep checking the e-portal and please submit your assignments at time, right? On time. So thank you, everybody. Have a good day.